A pandemic glossary with a focus on COVID-19. There are a lot of different scientific and epidemiological terms and concepts used in the scientific literature and debated and batted around in the lay media. A basic understanding of these terms and concepts will enable us to better analyze and understand and use the information we are hearing. In the next couple of slides, I will highlight words and constructs that are often used when addressing and talking about the COVID-19 pandemic specifically. A good place to start is trying to define what is an epidemic. The occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time. In this slide, I've highlighted outbreaks that occurred in the states of Washington, in Oregon, and California, but they are contained within those areas and they don't spread any further. A pandemic, on the other hand, it's an epidemic occurring over a very wide area, several countries or continents, and usually affecting a large proportion of the population. Examples from the literature as well as from history, obviously: cholera, AIDS, pandemic influenza, SARS, COVID-19, and we can go even further back to the Black Plague and even further than that, obviously. Looking at specific terms used when we talk about an epidemic, the first one we hear a lot about is quarantine. Now, the definition of quarantine is a restriction of movements and contacts of an individual without signs or symptoms of disease. The word quarantine actually comes from quarantena, meaning 40 days in Latin. It was used actually during the 14th and 15th century, and designed the period that all ships were required to be isolated before passengers and crew could go ashore during the Black Plague. And the reason for that was, at that time, they thought the incubation period, meaning from the time someone got infected until they developed signs and symptoms of disease, was around 40 days. So if we kept these individuals away from other individuals, or the potentially infected individuals away from individuals they could potentially infect for 40 days, we could be assured that we're not going to continue to spread this disease. And that's what quarantine is all about, meaning individuals that are presenting themselves as healthy but could potentially be infectious. So we'll wait for the incubation period and then we'll see what happens. Mass quarantine, or cordon sanitaire, it's a larger type of restriction of movements on contacts. For example, during the COVID-19 epidemic, at that time was only an epidemic, in China, the Chinese authority imposed actually a mass quarantine on the city of Wuhan with 11 million people. Another concept is isolation. Now, isolation is different than quarantine. While quarantine restricts movements in contacts of an individual without signs and symptoms, isolation restricts movements in contacts of an individual with signs and symptoms of disease, meaning if someone has been diagnosed with, in this case, COVID-19, well, we put them in isolation, meaning we'd isolate them so they cannot come in contact with anyone else. So, difference between quarantine and isolation. Quarantine, perceivably healthy but maybe an incubation period individuals. Isolation, individuals that have already been diagnosed or have signs and symptoms of the disease. Herd immunity. It's something we also hear a lot about. It's the resistance to the spread of a virus due to increased immunity among the population. And this type of immunity can occur different ways. One could be through vaccination, and another way could be that people get exposed to this disease or a disease and then develop immunity. Let me show you what it looks like. So you see the blue guys here, they are not immune but still healthy, and the orange one or the gold are immune and healthy, and then you have the red ones. Those are the individuals that we designate as not immune, sick, and contagious. So in this group of individuals on the left hand side, you'll see a lot of non-immune individuals that are healthy, and there are 2 individuals among this group that are sick and contagious. So over time, what will happen is they will spread this infection throughout the population. Now, another scenario could be that there are some people in this initial population that are immune. So now you have the infected individuals, you have those who are not immune, still healthy, and then you have those who are healthy and immune. So in this case, well, the disease will still spread, but it will only spread to some people in the population because those individuals that are immune obviously are not going to get it. And then you have the third or last scenario where you have a lot of immune individuals in the population, a lot of individuals that are not susceptible to get the disease. And as most of these individuals are immune, then obviously the spread throughout the population is contained. So how do we achieve this herd immunity? Again, either through vaccination or immunization, or enough individuals have been exposed to COVID-19, develop immunity, and therefore it contains the spread of the virus throughout a larger population. Flattening the curve. This is a concept that depicts measures to slow the progression of an epidemic. And usually the way we are looking at this graphically is that the pandemic in this case starts with a peak, meaning an enormous amount of new cases, an exponential growth of cases, and they grow so fast, exponentially, that the capacity of the healthcare system cannot deal with them. So what we're going to try to do during this pandemic is to try to mitigate the progression of the pandemic, lower the number of infected individuals by different type of strategies, and we're going to talk a little bit more about those later on, until we come to a point where the curve has flattened enough that the healthcare system will have the capacity to take care of them. Now, we can do that two ways, obviously, or in combination of two ways. One is less individuals getting infected, and we will then have less individuals in need of the healthcare system. Or we can increase the capacity of the healthcare system by having more doctors, nurses, hospital beds, ICU, ventilators, and so on and so forth. So that's the concept that people are talking about when they mention flattening the curve. Lockdown and shelter in place, extreme measures to diminish contact between individuals in populations. Today, which is April 11th, 2020, it's estimated that 4 billion people in the world are under lockdown. It's almost 50% of the world population as a whole. In the United States, 97% of people in the United States are under some type of lockdown. Social distancing is a simple strategy. It's hard to implement, but it's simple. It means that when we meet someone else, we should keep a certain distance from these individuals. For example, in Europe, the social distancing is supposed to be around 1 meter or 3 feet. In the United States, we like to have social distancing a little bit further, 2 meters in between individuals, meaning when you go out and you are socializing, although you shouldn't socialize, but when you go out and meet someone, you should try to avoid being closer than 2 meters and 6 feet. You're in the supermarket, you're in a store, try to keep that distance. That's social distancing. And that measure of how far you should distance yourself, it's a function of what we believe is the distance it would take for infectious droplets, in this case, from an infected individual to reach us and being able to infect a susceptible individual. Two other things that we hear a lot about. One is attack rate and the other one is secondary attack rate. There's a little bit of difference between the two. The attack rate are number of new cases of disease during a specific time interval as a proportion of the population at that start of the time interval, meaning how many people in a country, United States, over a specific period of time have developed this disease as a proportion of the population as a whole. That is the attack rate. The secondary attack rate are number of new cases among contacts as a proportion of total number of contacts. So the secondary attack rate is a concept that we use, for instance, in healthcare settings, in schools, even at home, where we have an individual that has developed a disease, and then we figure out how many of the people did this individual have a contact with actually developed disease. And that is the secondary attack rate. R0, R0, it's the reproduction number of a virus, or the expected number of individuals being infected by an infected individual. For example, if R0 is over 1, that means that one individual will infect more than one individual, meaning it will be a progression of the pandemic. The pandemic is not slowing down. What we want to try to do is we want to try to get that R naught below 1, meaning we're going to have less and less individual being infected. So the R naught, if it's above 1, each case on average, each infected case on average, is giving the disease or is transmitting the disease to at least one other person, and we can see growth of the epidemic or in pandemic in this case. If it's less than 1, then a group of infected individuals are generating less infection, and eventually the pandemic is going to die down. So R naught is the product of duration, opportunity, transmission probability, and susceptibility, and it's being abbreviated as DOTS or DOTS. So if we can change one of those variables, the duration, the opportunity for transmission to occur, the probability that transmission is going to occur, and the susceptibility of the individual that may get infected, well, in that case we can actually slow down the disease and less people are going to get infected. The duration is how long someone is infectious. So if someone is infectious twice as long, then obviously that individual has a possibility or potential to infect people for a much longer period of time. Opportunity, that's a measure of how many people you come in contact with for every day you are infectious. With something like the flu, you're not infectious very long, short duration, but a lot of your interaction could potentially spread it. So it's an opportunity, much higher opportunity to spread it. Transmission probability is the measure of the chance that the infection will get across during the interaction, and obviously we can mitigate that by, for instance, wearing a mask. Susceptibility measures the chance that the person at the other end of the interaction will pick up the infection and become infectious themselves. So obviously if we have herd immunity, it's going to be less susceptibility in the community, or if more people get vaccinated, if we eventually get a vaccine, then the susceptibility will go down. So each one of these variables will affect how many other people one infected individual will, on average, will be able to infect. If I look at R naught for the flu, it's 1.2, meaning on average, one infected individual with the flu can transmit it to 1.2 others, or 10 individuals can transmit it to 12 people. For the measles, one person on average who is infected with the measles can actually transmit it to 12 or 18 people. And it's estimated that R naught or R0 for SARS-CoV-2, the virus that causes COVID-19, the R naught is estimated to be between 2 and 3. Growth rate. This is the changes in new cases as a ratio of previous cases. And I'm going to show you more details about this in the next couple of slides here. So we are looking at something called the exponential growth of an epidemic. It may look a little bit complicated here and daunting, but bear with me, it's not that difficult. On the lower left side here, in the lower left corner, you will see a link to a YouTube video that is excellent, by the way, when it comes to explaining the exponential growth much better than what I do here. But I have taken a lot of the data from that YouTube video. So if you want to go to original, please do, or hang around here for the next couple of slides and I'll see if I can explain it, what exponential growth of an epidemic is all about. So N subscript D, number of cases on a given day. E is the average number of individuals exposed to a contagious individual each day, and P is the probability of each exposure becoming an infection. Now, if I want to see the changes of the number of cases on a given day, meaning delta N subscript D, it's actually the product of the average number of individuals exposed to a contagious individual each day times the probability of each exposure becoming an infection times the amount of individuals that were infected on the day where I started to see the change. If I want to look at ND plus 1, meaning the next day, well, I still have the same expression, E times P times N subscript D, and I add to that now how many cases were actually confirmed the day that I started to make this calculation. We can actually make two different type of mathematical expressions after this, and this part of the expression is very interesting. It's very, very similar to accumulated interest. If you put $100 in the bank and you get 5% interest, after 1 year you're going to have $105. After 2 years, you're not going to have $110. You're actually going to have $110.25 because the 5% is now calculated on the $105 and not on the initial $100. The third year, you are now going to have $115.76, and the reason being that now you get 5% on the $110.25. This is the accumulated interest. Here is exactly the same thing. So in my example here, you have this expression being 1.19. So if I look at the growth rate of 1.19, and this growth rate is not mitigated in any kind of way, it continues at exactly the same rate for 31 days, up to the power of 31, and I start out with 21,000 people that are infected. After 31 days, with a growth rate of 1.19, we're going to have 4.6 million infected individuals after the end of those 31 days. If I can lower the growth rate to 1.15, after 31 days, I will have 1.6 million people. And if I can lower it even further down to 1.05 after 31 days, we'll have only 95,000 people. So how do I lower the growth rate according to the expression you see here right now? Well, if we can lower the average number of individuals exposed to a contagious individual each day, we can isolate them, social distancing, and lower the probability of each exposure becoming an infection, again, masks and so on and so forth. For instance, if we can have some type of medication that could prevent an exposure actually becoming an infection, we can now lower this growth rate. The way we are graphing a growth rate is through something we call logistic curve. The logistic curve starts out with very few cases, and then exponentially the cases grow until they reach an inflection point. At that point, the growth is going to slow down, so the upper part of this curve after the inflection point actually describes the slowing down of less cases. So this growth rate, as I mentioned before, is a ratio between the changes of new cases in one day divided by the new cases of the previous day. Let's put that into action and see what we find. Again, these are the numbers I actually took from this YouTube video that I mentioned previously. So here we have cases March 3rd, March 4th, March 5th, March 6th, and then an additional day, let's call it March 7th. If you look at the changes between March 5th and March 6th, you had 3,530 more cases. Between March 6th and March 7th, 4,059 cases. And if we divide them if we divide those numbers, we get a quotient of 1.15, meaning we have a growth rate of 1.15. Now 1.15 means that it's more than 1, meaning we still have growth. We haven't reached yet the inflection point. If the change was not different, meaning if the change of number of cases were not different between the 2 days, between March 5th, March 6th, or March 6th and March 7th, meaning the change was 3,530 cases between March 5th and March 6th, and 3,530 cases between March 6th and March 7th, if we divide those by each other, we get 1, which means there's no growth and there is no diminishing growth either, meaning we have reached inflection point. It's stable. The pandemic will continue. It will not grow, but it will not mitigate. It will not slow down either. What we want to get to, though, is that we will want to have less and less individuals getting infected. So we're looking now at the change between March 5th and March 6th being 3,530 cases, but between March 6th and March 7th the change was less, so it's only 2,824 cases. If we divide those two numbers, we get a growth rate of 0.8. Now 0.8 is less than 1, which means we have now reached and gone beyond the inflection point, and we now see a slowdown of the epidemic. And this is how the modeling is being done, the modeling that you hear a lot about, how long time it's going to take until we get to this inflection point, and when it's going to have the growth rate is going to slow down, and when are we going to be able to see an abatement or progression of this epidemic or pandemic. And this is one of the measurements that people are looking at in these models. Case fatality rate, percentage of someone with a disease that will eventually die from the infection. Now the case fatality rate is really complicated Because in order to know the true case fatality rate, we have to have a definition of the disease. So today, there really is no confirmation of what is a disease. Meaning, someone with COVID-19, is it enough if they have signs and symptoms and continue to deteriorate with very particular specific signs and symptoms, or do they also need to have a test done in order to confirm this case? There's not really clear how people are looking at confirmed cases even within a country, and between countries obviously not. So there's no agreement yet what constitute a confirmed case. So therefore it's very hard to know if the case fatality rate is the same if we compare from country to country. What we probably should talk more about in that case is the infection fatality rate. The infection fatality rate is the number of deaths from a disease divided by total number of cases. That could be a little bit broader, meaning we don't have to have maybe laboratory findings. We could be enough for signs and symptoms, and we have a differential or a tentative or presumptive diagnosis of the disease, and then we divide it among the cases, and then we find the infection fatality rate. But you will hear the case fatality rate being batted about all the time. If I look at the case fatality rate, and this is a slide from the European CDC, it's from April 3rd, and you can see on the diagonal lines that go from the lower left corner to the upper right corner that depending on country, the death rate is very different. If I look at Italy and Spain, for instance, they have a very high death rate. It's over 10%. Germany is only around 1%. New Zealand is very, very low. So how do we change the death rate? Well, again, it's very tough to be able to get the right information, because in order to know how many people have died of the disease out of those who have been infected, we need to know how many have been infected. And unless we start to do more testing, we will not know what the denominator is, meaning we don't know how many people truly are infected or not. So although these numbers that you see in front of you here are probably fairly accurate, they probably are not comparable between different countries. But within a country, if they calculate it the same way, you will be able to see changes. So could, for instance, in Italy, could the death rate go down from 10% to 8% to 6%? Hopefully we're going to see that in every country. If they use the same definitions of cases and infection and how to confirm someone is infected, well, in that case, you will see there's a change. So we can compare death rate or case fatality rates, but we have to be careful depending on the definitions countries are using. Point prevalence is very simple. It's a snapshot in time. The number of current cases is a ratio of the population at the same point in time. How many people you have in the population that have been infected. In the United States today, it's over 400,000 cases. You divide about 330 million people live in this country, and you get a point prevalence. It will not tell you what the incidence rate is. It will not tell you how many cases will develop over a certain amount of time. Again, it's just a snapshot in time. That's all it's going to give you. SARS-CoV-2 was the scientific name given to this virus. And SARS stands for Severe Acute Respiratory Syndrome. CoV stands for coronavirus, and 2 obviously is 2. And this virus will cause a disease called COVID-19. So COVID-19 is a disease caused by this specific coronavirus. There are other coronaviruses that caused pandemics in the past. One was SARS, and that's now called SARS-CoV-1, by the way. Another coronavirus that caused an epidemic was actually MERS, or the Middle Eastern Respiratory Syndrome. All of these are what we call zoonotic diseases, meaning somehow, somewhere, the illness originates from a virus that actually came from animals, usually wild animals, and somehow infected humans. And I'm going to show you in a couple of slides what we believe is the case when it comes to COVID-19. So SARS 2003, it was believed was bats in MERS 2012, it was believed was dromedary that actually was the origin of, that originated the coronavirus that eventually infected humans. And when these viruses go beyond where they usually are found, we call this a spillover infection. So it occurs when a reservoir population with a high pathogen, such as bats, encounters a new host population, maybe another animal that they can infect, or even humans. So this is what it might look like. You have the coronavirus here that could be found in bats, and we have found a genetic homology here. They're almost identical, the viruses we found in specific species of bat and the coronavirus that now infect humans. They are very, very similar genetically, so there's very little doubt today that the source of this virus actually came from the coronavirus from a bat population. Now, this virus can now infect another individual, an intermediary host. In this case, could be the pangolin. SARS, COVID-1 was actually civets. It was thought to be the intermediate. You can also have geese during the bird flu, and so on and so forth. Well, then you have the human viruses, obviously. So all this comes together, unfortunately, and you get a reassortment of a virus. And this reassortment of the virus will then be able to infect humans, or the humans can be infected directly from the coronavirus from the bat. And obviously, when humans get infected with a virus that they have not experienced before, they will not have immunity. And because they don't have immunity, and depending on how the immune system will respond to this new virus, they will develop severe diseases and become infectious, and then can obviously continue to spread this new reassorted virus. And this is what we see now in the pandemic with COVID-19. What is the incubation period? The incubation period is the period between exposure to an infection and appearance of the first signs of symptoms. Now, the incubation period is the period where people don't show signs and symptoms. Now, with COVID-19, this is a very important period in time because it is thought, and we have seen numerous cases where individuals we know now retrospectively that they were infected, but they had no signs or symptoms, and they were still able to transmit the disease. So with COVID-19, there are ample evidence that even during the incubation period, during this period where they have no signs or symptoms, people can still transmit the disease if they have been infected. A confirmed case, an individual with signs and symptoms of disease, sometimes in conjunction with a confirmatory laboratory test, and again, as I mentioned earlier, it may actually differ a little bit from jurisdictions to jurisdiction. What is a confirmed case? An active case is an individual that is still considered afflicted or still has the disease. It's an active case. And if someone has recovered, we call it a recovered case. And fatal cases are obviously individuals that actually got infected with SARS-CoV-2 and developed COVID-19 disease and died from the disease. Viral load is the amount of virus that we can measure. And the viral load is important because we don't know today what number, meaning how many viruses are truly needed in order to cause an infection. What we're trying to determine is what we call the minimal infective dose, the lowest number of viral particles that cause an infection of 50% of individuals. Another issue with the viral load is that if someone, for instance, has a very low viral load in the throat or the oropharynx, and it's from that site that we actually take some samples in order to measure it, and the individual who is supposedly infected doesn't have enough viruses there, maybe we don't get enough sample, so the test is going to come back positive. So the viral load is very important for many different reasons. You will also hear a lot about the cytokine storm. The body uses the cytokines in order to trigger an inflammatory response. Now, a cytokine storm is an overreaction of the immune system and triggers a very, very uncontrollable inflammatory response. This could be one explanation why very young individuals, 0 to 5 or 0 to 6, that don't have a completely developed immune system yet, maybe they don't have the ability to develop this severe inflammatory response, meaning the cytokine storms don't develop in those individuals, and therefore these very, very young individuals are not going to have the severe signs and symptoms of disease. And this is exactly what we're seeing from an epidemiological standpoint. On the other hand, if you look at individuals, the age group of 20 to up to 50, we thought in the beginning of this pandemic that elderly individuals are much more susceptible, and that's still true. But now we also see individuals in this age group between 20 and 50 developing the disease. And one explanation could be there again, that they have an out-of-control reaction to the cytokines. Cytokine storm could be one of the explanations why we see different signs or symptoms, and some people get a mild disease, some severe, some are critical, and some may actually succumb to the disease itself. Ventilators, PPE, respirators, or surgical masks, something we know quite a lot about in dentistry, but let me go through them very quickly. So ventilator is a machine that moves air in and out of the lungs when a patient cannot or having trouble breathing on their own. PPE, personal protective equipment, masks, gloves, face shields, and so on and so forth. A respirator is a face mask that seals around the mouth and filters out particles from the air before they are breathed in. And a surgical mask or face mask is loose-fitting masks that don't filter out as many particles as a respirator. Now, we have to be very careful when we're saying that, yes, we should use a respirator because a respirator will remove a high percentage of particles that are larger than a certain diameter. Well, that is true, but they have to be fitted. So when you use a respirator, such an N95, or in Europe we talk about the FFP1 or P1 or FFP2 and P2, they need to be fitted. If you don't fit the respirator, in that case it's not going to work very well. And you also have to realize that this respirator that are being fitted, you will use the same type of respirator later on. If you change brand, you may have to do the fitting over again. So just using the respirator without the fitting part of it, you don't know how good the seal is. The number that you see associated with respirator, N95, N99, N100, or FFP1, FFP2, FFP3, and P3, is a designation of the percentage of all particles that are 0.3 micrometers in diameter or larger that these masks can actually filter out. Now something else we now hear about is something called the PAPR, and powdered air purifying respirators. Here's a couple of samples from different companies that have these PAPR. California, as of yesterday, and we talk about April 10th, recommended that if you are going to treat a COVID-19 positive person, that you use these powered air purifying respirators. If you don't have that available, you can always treat the patients with an N95 mask, but please beware that it needs to be fitted in order to be able to give you the protection that it can give you. And the protection, we are trying to protect ourselves from our aerosol. So aerosol is suspension in the air of particles small enough that they remain airborne for prolonged periods of time. And how long they become airborne is a matter of how large these droplets are. So the viruses that we're talking about, they're contained within these droplets. And these droplets are the ones that are going to be transmitted from an infected individual to non-infected individual to someone else. Large droplets, they will not settle in lower respiratory tract, but the smaller droplets, and those are the droplets we talk about when we talk about COVID-19, they could actually be suspended in the air for a couple of hours. Now those small droplets can actually settle into the lower respiratory tract. The differentiation between large droplets and small droplets, arbitrarily today we're looking at 5 micron or 5 micrometers, meaning below 5 micrometers we are defining droplets as small. Above 5 micrometers we are defining droplets as large droplets. You also hear a lot about reverse transcription polymerase chain reaction. Now PCR, or polymerase chain reaction, is a technique that is used in order to find genetic signature of a virus, or actually of a DNA. So the PCR will detect the DNA of a virus, and RT, meaning reverse transcription polymerase chain reaction, is used to find the RNA, and this is an RNA virus. So therefore you're going to see the reverse transcription polymerase chain reaction test. These tests are very, very accurate, and they look for the antigen, they look for the virus itself. There's another technique that you haven't heard too much about yet, but you probably will, and it's something called reverse transcription loop mediated isothermal amplification, or an RT-LAMP. It's another amplification technique to detect RNA, and this one is not as complicated as the PCR technique. The PCR, you have to change the temperature a couple of times up and down. In this one you don't. That's what's called isothermal amplification, and it's possible that this technique, the RT-LAMP technique, could actually be a very effective point of care test, meaning a test that you can use chairside in order to find out if someone has a virus or not. And then we have the antibody tests. Obviously antibodies is the body's immune response to a disease, and the antibody test will only show you if you have presence or absence of antibodies. I'm not going into more details about this, but just so you know a little bit right now, when it comes to the antibody tests for COVID-19, there's only been and today, April 11th, there's only been one antibody test that has been approved by FDA, and this antibody test will look for both IgM and IgG. Now, an antibody test is not the antigen, it's not the virus, it's the body's response to the virus, and it will tell you if you've been exposed to the virus. It will not tell you much more than that, unfortunately. Now, any type of test, and it can be an antibody test, it could be an antigen test, has a sensitivity, has a specificity, false positive, false negative rates. And this is something you really need to be very aware of. So if I look at the test sensitivity, the sensitivity is the percentage of individuals with a disease that will test positive for the disease. Now, those who have the disease but test negative, we call those false negative. So individuals with a disease that will, when the test comes back negative for the disease. It's estimated today that the false negative rate for some of these tests that were used for COVID could be as high as 30%. And the reason for that most probably is not because the test isn't good enough. It could probably depend on that the sample we are taking is not good enough, meaning we don't have enough viruses in the sample from the site, from the anatomical sites where we are collecting the viruses, that it will enable the test to give you a true positive result. So 29 to 30% false negative rate is something that we have seen in the literature at least today. Specificity is the percentage of individuals without the disease that will test negative when testing for the disease, meaning if you don't have the disease, what is the ability of the test to determine that you do not have the disease? Now, obviously, if you don't have the disease and the test come back positive, we call this a false positive results, meaning individuals without the disease that will test positive. So any test that you look for, that you have and going to use, find out what the sensitivity and specificity is. If a test has a high sensitivity specificity, it's very accurate. If it's low sensitivity or low specificity, in that case, obviously the accuracy is not going to be that great. I want to end this just with a couple of abbreviations that we hear a lot about, and there are many more, but these are the ones that I've seen in the past couple of days or weeks. EIND, Emergency Investigational New Drug, meaning a drug that physicians get permission to use even though they haven't gone through the entire approval process yet. So emergency investigational new drugs, meaning even before they've been approved, they get an approval, an authorization to use the drug anyway. IDE, investigational device exemption. EUA, emergency use authorization. For instance, these new tests that are coming out, they haven't gone through the whole approval process, but because of the emergency that's occurring right now, FDA will give an authorization to use them. PUI, persons under investigation, or individuals that have yet to be diagnosed. NPI, non-pharmaceutical intervention, for example, social distancing. ELISA, enzyme-linked immunosorbent assay, is a test that being used in order to look for antibodies. And POC, very simple, it's point of care, meaning a test that we can do chairside. So I hope this was helpful, and I hope I could clarify some of these terms and concepts that you hear a lot about. Thank you very much for your attention.